This is Dr. James Waxmonsky from the Herbert Wertheim College of Medicine at Florida International University.
And this is Marie Albano from Columbia. We're very honored to have here at our conference today.
I'm actually inching to get a part-time visiting position in the winter at FIU. So
I'll trade you. I'll do.
You want to do that?
Let's swap.
There we go. We've got a deal. We're going to talk to you about the internalizing disorders this afternoon, and we're going to do like a, sort of dog and pony show. Or do we have maybe Jekyll and Hyde? No, I don't know.
We'll see how it goes.
We're going to go back and forth this afternoon covering anxiety and depression. Okay? And so if that's the workshop you want, we're the people. We're going to be covering psychopathology very quickly. I'm going to do speed dating. We're going to do speed diagnosis to get through that, because what we want to get to is the evidence-based treatments, psychosocial and medication, and especially we want to talk about and answer questions about the combination treatments and such, and how we work within our respective universities and clinics with our colleagues in psychiatry and psychology, social work, counseling, and stuff to bring the best to kids who are in need. All right, so you jump in anytime. I'm going to start this out. So here we go. And of course, we always have to start these days with disclosures. And I think, Jim, you'll have a slide on disclosures, maybe?
When I start, I'll have my own.
But this is where I get funding and sometimes royalties and things like that, just so you know. Okay, I don't have stocks. I don't know what to do with stocks. My husband always yells at me about stocks. You have to pay attention. What do you know? It goes up, it goes down, it goes up, it goes down, whatever. Okay, speed dating on the diagnoses. To get a sense of what we are covering today and what the research that we'll talk a little bit about, but really where our clinical work goes, going to go very quickly through the main diagnoses that we're talking about and some of their related friends. So that if you have questions, you think about cases that you have that fit within these categories. And let me say this up front. I'm not big on categories, except that why we need to having a good understanding, and we look at things in terms of diagnostic categories, is because, number one thing, it does help us in beginning to understand and do a formulation of what's needed for this child in terms of developing a treatment plan. So if you see a cluster of symptoms that are reliably and repeatedly co-occurring, interfering in functioning of the child, you can understand a bit more about the psychopathology and also the way that cluster integrates and interacts with other clusters around it. So diagnoses are important in that way because it also helps us nowadays with prescriptive treatment, which is matching the primary issues to a treatment plan that has the best potential for turning the child around. Okay? The other thing, unfortunately, yes, it's true, we need to have diagnostic codes for reimbursement if you're working in practice settings. Maybe different in school settings, where you won't necessarily have to put in a diagnostic code, but if kids are coming to your clinic, we always have to assign a code. So anyway, what we're going to be talking about today then, in terms of the anxiety disorders, to start there. Separation anxiety disorder, the little Klingons. These children classically, wait a minute, before I move on, hold on, I'm backing up a second. Let me just get a show of hands so we know who we're talking to. School-based practitioners. Okay? Private clinic, private practice settings. Community mental health practitioners. Okay. Hospital-based clinics. All right. Who am I missing? Students. Okay. And all the students. All right. Okay. Everybody has to take a student home and give them a job after this talk. Just so you know. All right? There we go. All right, just so we know, because what I want to do is we especially talk about CBT is how we adapt it to the different types of settings that you're working in. So with separation anxiety disorder, right away, children will become anxious as evidenced by the way they talk, the way their behavioral reactions of shaking, crying, begging, pleading, hiding, clinging, doing a lot of things to prevent separation from the primary caregivers or home. And the issue here is that they're worried that while they are away at school or in daycare or at a friend's house or at a after school event or something, while they are separated from their loved ones, something terrible is going to happen that will prevent them all from being reunited. The child is standing outside of school, and as one of the teachers or a counselor there, you're observing this child who's shaking and starts crying. What's wrong? My mommy's late picking me up. What that child is envisioning is a car accident on I-95 or somewhere that mom is in, and that they're not going to see mom again. Okay? So bearing in mind with separation anxiety, it's always a fear that something terrible is going to happen. The thing at night, the child doesn't want to sleep in bed by themselves. They're in between mom and dad. What is the image in their mind? Someone is climbing through the window to get to them, to take them away. And thank you, media, that exploits every unfortunate child abduction case. Kids know these things, or they get a sense of it, and they get afraid. So the symptoms of separation anxiety, really, the parents will call their kids Klingons. Parents tell me they step back from the sink, or they're washing dishes, and they step on the child who is camped out behind them silently on the floor. They get out of bed in the morning and step on the child who they've said, no, you can't sleep with us, so the child is on the floor next to the bed. They want to be near mom and dad. So you need these, 3, I think, of the 7 symptoms in order to qualify for SAD. It has to interfere with the child's functioning at home, at school, their interpersonal functioning with friends, things like that. The age range, we find this hitting early, 4 to 5 years of age, when kids are just asking to be more independent in terms of longer school days. We also see it at the point where they're changing from elementary to middle school, and things are getting more confusing. Bigger schools, they're more afraid they're going to get lost in those crowds and such. And you see it in the older kids, but here's an interesting thing. It goes underground a little. And it goes underground a little because teenagers are able to make decisions for themselves. So they, by this point, by adolescence, they've dropped out of the after-school activities. Parents give up. They can't get them to go anymore, so they're home more. And they don't call friends to go over to their house, but they'll have friends over, and they're social enough when they have friends over. So parents think they're going to, and they sort of bear in there with going to school and coming home, going to school and coming home. The parents think they have a lovely kid who gives us no problems. But the time comes to send them off to college, and it's failure to launch syndrome because they're not leaving home. They don't want to go away to school. So watch that. Community colleges filled with separation anxious kids. Social phobia. This is largely a disorder of adolescents, although we do see it in younger children too. This is the fear that you're going to be the center of attention, you're going to be looked at or evaluated, you're going to be rejected or humiliated in some way in front of others, and it'll cause such embarrassment to you that you can never face these people again. So you can see why we call it the teenage disorder. We separate this from the kids who can never walk past a mirror without going, yay, like this. Those kids are comfortable in social situations. These kids are not. These children are always afraid that they are going to do something that will forever be embedded in the school yearbook, or put on nowadays on Facebook and YouTube as, look at what this geek has done. And you know what? It's become a reality, as we heard in some of the talks this morning, for some of these kids. These kids will white knuckle through their day because to not do that might bring them more attention. So my classic young man that I worked with with social anxiety rather, that I always talk about, was 16 years old, and when I met him to do an evaluation on him, what he described was when he woke up in the morning, before he even opened his eyes, he was sick to the stomach knowing he had to go to school and be around other people. He timed it to get to school at exactly the time he needed to, into the class, without having to talk to people, and just as the bell's ringing and class starts, so he didn't have to make small talk. He always sat behind a taller, bigger person to try and not be noticed by the teacher, make himself look busy so she wouldn't call on him, and then at lunch period, he sat in a bathroom stall and ate his sandwich. And this was a nice-looking young and very personable young man. But he was so frightened by the idea of messing up in front of other kids in some way. That's social anxiety. In its extremes, we see it as selective mutism, especially in young children. So these may be little clinging kids to their parents at the nursery school and in kindergarten and first grade, but it's not because of separation. It's because they're afraid of the people, the other kids, teachers, they don't want to talk to them. And especially when they're young, they learn not to speak. Think about anxiety. The fight or flight response also has a freeze component. Selective mutism is the freeze. And what happens, and we'll be talking about parents as we move along, is, especially when they're young and it's a little cute, you'll hear, "Oh, Toby is shy. Come on, Toby." "All right, well, I'll ask you. Toby would like," and mom or dad will speak for Toby. And then they become identified as the child who doesn't speak. So anyway, selective mutism is a variant of social phobia, but we do see it more in kids who are pubertal or later. And adolescents, we call it pretty much the anxiety disorder of adolescence. Generalized anxiety disorder, the worrywarts. For those of you in school settings, the teacher's saying, "Please do something for that child who's constantly what-ifing me." And parents hear this too. "Excuse me, Mrs. Smith, I know that you assigned us to do this math page, but what if I don't get all the answers, or what if I misunderstood you, or what if I want to go on to the next page, or what if?" Okay, parents will hear, "We're going on vacation. What if there's not a doctor and somebody gets sick and we're in a place camping and we can't get to a hospital, and then what if daddy tries to go to the hospital to get us some medicine, and then what if?" And they think like this. The parents will call them little adults because they worry more about finances for the house and the economics of things going on than the parents do. "What if you lose your job? Daddy, did you see the newspaper today? What if?" These children worry no differently in terms of the things they worry about than the average child. It's that they can't turn it off. The average child may have a what if or two, and you can redirect them. You could get them engaged in another activity, you can move them along. This child will be redirected for a few seconds, and they're like a rubber band. They go back, they snap back into place. What if? So their worry is difficult to control. And then they typically present with some kind of associated stress-related symptom, such as stomach upset, headaches, stomach aches, like that, or restlessness. These are the kids who look like ADHD kids at times. Because in class, they're constantly out of their seat, not because they are impulsive or hyperactive, but because they always have questions. But that topographically looks like a hyperactive kid. And they're always on edge because they're always anxious. And they can get irritable. Plus, they'll have sleep disturbance, and a lot of time it's because they can't shut it off at night. So these are our little worriers. These kids typically worry about future events, and it could be about anything that you can name. Going on, even happy things like going on vacation, family members' health, the pet health, their pet's health, you name it, they're going to worry about it. Okay? GAD, or generalized anxiety, can start as young as age 4, but typically, again, this is a middle school age diagnosis. And the reason why goes along with cognitive development. It's around that time when children are able to take the perspective of others, able to think about longer-term consequences and stuff. And also, at the same time, we are expecting more from them in the terms of handling their academics and social demands, a little more independence and so forth. So GAD really pops up in that age range. Now, the question that always comes up, and one that psychiatrists and psychologists we get a lot of referrals for, in October and February. The disorder that goes away for the summer is school phobia, which really isn't what we call it anymore. We call it school refusal behavior. This isn't a disorder. This is actually a behavioral expression of something underlying. The refusal to go to school, the inability to sit during the course of a day and stay comfortably in school rather than going to the nurse, having to call home, having to check on mom, is telling us something's going on that is probably an anxiety or a mood issue. That's separate from the kids who are refusing to go to school because they're truant. Bill Pelham will deal with those kids, and Mark Atkins and others who work with externalizing. I would like to work with the worriers and the kids with internalizing disorders because they don't tear up my office when they're in there with me. So with school-related, school refusal rather, the thing is we have to find out what is motivating the behavior to want to stay out of school. First thing is typically they want to escape something that brings up a very negative feeling and mood, an anxiety state. So these are usually the kids who are worriers. Oh my gosh, what if she gives us another test? I can't handle it. There's so much, right? These are the worriers. These are also kids who are phobic of something. When I worked in Kentucky, we had school refusers who were afraid to go to school because of the potential for tornadoes. They didn't want to get caught in the school during a tornado. It could be also, kids who have panic disorder or panic attacks in school. They want to be home, not at school, because if they have a panic attack, which to them is misinterpreted as something terrible has happened to me physically, which is what panic is. Most adults, we think of it as, oh my gosh, I'm having a stroke or a heart attack because of the surge of autonomic reactivity. Kids think I'm getting sick. The only thing they know is I feel better when I'm at home, when I'm with mom or someone who could help me. So they're trying to escape something that makes them feel bad. The depressed teenager or child, school is not reinforcing to them. People are making plans. People are achieving, they're enjoying the work, even though, we don't enjoy every class, but there's a class that's a favorite to them. The depressed kid finds no reinforcement in the environment. So they escape school and feel better. The second reason is to escape the social situation and social context of school. These are kids with social anxiety, social phobia. So these first two reasons for refusing school, when I stay home, I feel relief. That reinforces me to stay home again and again. These are negative reinforcement reasons and paradigms for maintaining school refusal. The third reason is they get a lot of attention for their school refusal behavior. A parent brought a child to me when I first started working in New York City. The mother was seeing a long-term therapist of her own, was telling that therapist all about her daughter not wanting to go to school, not wanting to do sleepovers, not wanting to do a bunch of things, and the therapist said to the mother, she obviously fears your abandonment. You should let her stay home with you and do something nice, just you and her, like go to a museum, go to lunch, things like that. Positive attention for the acting out behaviors of separation anxiety solidifies school refusal. So the third reason on the internalizing spectrum for school refusal is separation anxiety concerns that get a lot of attention. And many parents are worried when they have anxious children, especially separation anxiety, that if they take a hard line, no, you can't, you must go to school, you must sleep in your own bed, I'm going to Ferberize you no matter how old you are. The parents are afraid they're going to do damage to that child's psychological well-being for the rest of the child's life, so they back off and they allow it to happen. So that's the third reason. And then the fourth reason for refusing school is because they may have started out with reason 1, 2, or 3, but they've been home for so long, their new friends are Ben and Jerry, who they have for breakfast at around 11:30 when they get up, and they get on their, FaceTime for the other school refusers or whatever they've got, connections to people. But these are kids who they've been out, and the reason has sort of faded to the background. What's maintaining the school refusal now is the fact that who would want to go to school when I could get to stay home? So these are the functions of school refusal behavior that has anxiety or depression underlying them. About 5 to 10% of kids will refuse school for this reason. These reasons, it's equal amongst boys and girls, doesn't show itself to be different depending upon the socioeconomic status of families. But we do see more school refusal taking hold and solidifying in the middle school years and into high school years. Why is that? If they know parents can no longer pick the kid up and throw him in the car and drive him to school. When the child gets bigger than the parent and starts fighting, and there's lots of stuff that goes around that, you know, the neighbors here in an apartment complex, they're in a, you know, the parents fighting with the child, call 911, there's something going on. You know, all kinds of things happen that parents back off and the kids wind up staying at home. That's a problem. And then, of course, we also see school refusal peaking at transition times, especially transition to a new school, starting school, a new school, or change from, you know, middle to high school, things like that. For these anxiety disorders, first of all, anxiety are the most common disorders of all the disorders. And the reason why is because we have many flavors of them. You know, you have ADHD combined type, ADHD inattentive, ADHD hyperactive, 3 types of ADHD. We have separation, social, GAD, and then don't forget we also have obsessive compulsive disorder, panic disorder, specific phobia with or without agoraphobia, post-traumatic stress disorder, acute stress disorder, selective mutism. Am I missing any anxieties?
I think you got them.
I think I got them. We got a lot of anxieties, and they really are prevalent in the population, adults, but also in kids. They're the most common of the disorders. The more common are GAD, social phobia, specific phobia, and separation anxiety. Social, unfortunately, has moved up. Sorry, from this slide. It should be up. And the thing we have to do is differentiate these anxiety disorders from normal anxieties and fears that we all go through in terms of ages and stages. So we need to do that and do it by using, you know, understanding the psychopathology and oftentimes using measures that are helpful to us. In terms of the developmental progression of normal fears, we know in preschool, imaginary objects and situations, things like that, things could go bump in the night are what kids are afraid of, so, and also separation situations. By grade school, they're worried about harm befalling them, doctors and dentists, thunder and lightning, tornadoes, and then scrutiny and competence, being good enough at things. And then finally, by adolescence, it's really social adequacy in a broader sense and performance. And so these are just the way that normal fears occur. There's a wealth of literature on that. And if you look up Tom Allendick's work, you know, Allendick has just cataloged fears for his whole career. He's like the master of understanding normal fears in kids. And then the progression of anxiety disorders, specific phobias onset very early, 4 to 5 years of age. Specific phobias are actually looked at. How many of you are pediatricians here? Anyone? Pediatricians or nurses? Okay, don't be afraid with the rest of them. You can raise your hand. The thing about specific phobias is for many, many years, people were told, don't worry about it, your kid will grow out of their fear of dogs, their fear of the dark, right? Their fear of water, their fear of heights, whatever it might, fear of costume characters. Don't worry, they'll grow out of it. Now, there is a normal fear of these things that should occur at times, and it's within like 4 to 8 weeks of exposure to these situations that a child should get over the hump and be less upset and more comfortable walking past the house that has a dog on a leash behind a fence. But if the child avoids and doesn't go near, and if the parent starts overprotecting the child about these kinds of fears, I'm sorry, Sally can't come to the birthday party if you're going to have a costume person or a clown or somebody who comes, you know, like that. Are you? Because I'll pick her up before him. I'll stay with her. Maybe we'll take her before that. Oh, my goodness. Are there going to be any loud noises like firecrackers because she can't hear those things? The more overprotecting that occurs, the more likely that fear stays there and develops into a phobic type of thing. And specific phobias have been found by Ron Kessler in the National Comorbidity Survey of Adults to be the disorder that predicts every disorder in adulthood. He considers it, and others in epidemiology now, the gateway diagnosis to all other mental illness. Okay, now schizophrenia and bipolar we're going to put to the side. Obviously there's a lot of biological underpinnings to those, but nonetheless specific phobias are there first. And then of course these other anxiety disorders, separation anxiety, worry, OCD, and so forth, they come later by 8, 9, and so forth years of age, their onsetting.
Sorry to interrupt you. Could you just repeat the name again of the researcher connected to that?
Ron Kessler, Kessler. He's at Harvard. He's a public health epidemiologist. He has run the National Comorbidity Survey back in the 90s, and most recently the Replication Survey. And also, he's the head of, over Kathleen Marikengis, who has the Adolescent Comorbidity Survey. Specific phobias are not innocuous. And we need to help pediatricians, pediatric nursing staff, and others to recognize the difference between fear and phobia so they can refer kids for help. Because they're highly treatable. In one session, phobias can be treated. And we'll talk about that as time goes on. Comorbidity of anxiety disorders are high. Again, gateway. If you have anxiety early, by the time you're an adolescent, you're more likely to also have depression, and then also to add in substance abuse. Okay? So bear that in mind. Anxiety is highly comorbid with other internalizing disorders, and then also with externalizing disorders, mainly with ADHD and oppositional defiant disorder. And if you have a kid with ODD, look to see, especially if they're 7, 8, 9 years of age, look to see if their oppositionality is functionally around something they want to avoid. We had a kid that we worked with at Bellevue Hospital in New York City. This poor kid had been hospitalized 3 times between the ages of 9 and 13 at Bellevue. He was referred to us finally at 13 to say, take a look at him, we don't know how to help him. It was for ODD. Evaluated the child, found out this young teenager, his oppositionality was because his obsessive compulsive disorder was so raging that he would get into fights with his parents and pushing and shoving and screaming and tantrums, running, leaving the house when he was confronted with his germ fears. If somebody drank out of his glass or touched his plate of food, he'd throw the whole thing across the room. He couldn't eat it. They thought he was just being an oppositional kid, and they had 3 times hospitalized this kid in the major psychiatric hospital of New York City without ever diagnosing OCD. We treated his OCD. He did wonderfully. So look out for that, especially when they're young. Most adults who have anxiety and depression report a history of childhood anxiety. Just to understand that there's stability of anxiety symptoms through childhood all the way into adulthood. Many anxiety disorders remit by follow-up. We're looking at, though, that there's this vulnerability that remains. If you don't stabilize the whole environment, and we'll talk about things, we don't know what the risk factors are that kick up those Achilles heels. Okay? Family genetics, just know these disorders run in families. I like doing our diagnostic interviews and I'm asking the parents about their child, and you got the mother and the father sitting there, and you'll say, oh, out of the blue, did you ever notice sudden rushes of anxiety or fear? And the parents going like this, look at this one. Or the big question I like to ask parents when it comes to asking about OCD, which one of you, I'll say, rearranges the dishes in the dishwasher to be perfectly in there? How many of you do that? All right, and that, for parents with OCD, typically that's one that they're like, well, yes, what's wrong with that? Okay, I had one father say to me, the mother left the room to use the bathroom, and the father says to me, is it a problem? Nobody was admitting anxiety of any sort. The kid had OCD all over the place. Is it a problem, Dr. Albano, when I get up to use the restroom in the middle of the night, I come back, the bed is made? These disorders tend to cluster in families. Now, the question is, we see a lot of social phobia cluster, And research by Abby Fire and others in the 90s at New York State Psychiatric Institute studying adults with social phobia. They found, good heritability estimates or strong heritability estimates for social phobia in families. Same thing with the specific phobias. Especially strong is something called blood phobia, where the people faint at the sight of blood. That has a very strong familial loading. But the thing of it is, we don't know, though, how much also is environment, right, and modeling effects. And we'll talk about that as we move along today. Because we know that parents of anxious kids do tend to swoop in, overprotect, overcontrol. They provide negative feedback, and I'll show you later today in interesting ways. Oh, I don't know if you want to go to that school dance because you haven't been to one, and, you don't really have friends there. Okay. And it's not meant in a negative way, though. They're meant to protect their kids. Because remember, from the age of 5, when these disorders start taking hold, they're comforting and, a child who's crying. So by the time they're in adolescence, the parents are used to helping the child escape and avoid. So, they sort of, help to maintain the problem without realizing it because they get drawn into it. Other risk factors for anxiety, traumatic events and psychosocial disadvantage are big ones. And sometimes we see some neurologic soft signs, hyperreactivity, and definitely behavioral inhibition, and those kids who temperamentally as babies are anxious and, clinging to their parents. Jim, you want to say anything?
The thing I would say, I think most of the studies will show what we see clinically is that these diagnostic boundaries aren't discrete, in that you'll typically, when you have one disorder, I would encourage people not to stop looking for the other disorder because there's high rates of overlap, particularly between social anxiety, social phobia, and separation anxiety in particular, and generalized anxiety disorder. So once you've found one thing, it doesn't mean you can't have the other things. In fact, if I remember correctly, the risk is quite high in all likelihood that you'll have another set of anxiety symptoms as well.
Yeah, it is really rare that we have a child. Our clinic we have a specialty clinic in Midtown Manhattan where all anxiety all the time, and it's rare that we have children come in with only one diagnosis. Maybe a phobia at an early age, but usually we are treating 2 and 3 things at the same time. And when we've done our large studies, which we'll talk about later, across, with sites across the U.S., the kids are largely comorbid. About 30% of the children in a 488 person sample, I think about 30% maybe had one diagnosis. The rest of them had 2 or more, up to 5 or 6 diagnoses of different types.
Yeah, and you'll also see it mixed. Just because ADHD is a very prevalent disorder, you'll see it with ADHD. I know you mentioned externalizing disorders. Anxiety and ADHD seems a bit counterintuitive. Because you're impulsive and inhibited, which really makes it very hard, makes it very contrasting symptoms in different settings. So in a non-anxiety setting, you'll see a lot of hyperactivity and impulsivity, and in a setting where the anxiety trigger is there, you'll see inhibition. So unless you're catching the child in the setting where the anxiety is, they'll look very different, and you may not see the ADHD in one setting, you may not see the anxiety in another setting. So you always have to. I always find it very helpful to focus parents on different settings, school, home, friends, or large group social activities, instead of just asking blanket questions about symptoms.
That's true. I should have brought this, I should incorporate this videotape. I have a great videotape of a 9-year-old little boy who had ADHD, combined type, plus he had GAD, and a strong specific phobia of spiders. Now, we didn't know about the anxieties. His parents were insisting there was also anxiety. We knew there was ADHD. I have this lovely videotape of my graduate student interviewing this child in a small interview room. The camera was over the graduate student's head. This kid is like, woo-hoo, follow the bouncing ball as he's trying to interview this kid and get this kid to tell him what's, talk to him. And he couldn't do it. And at some point, I don't know why, Thomas did this, but he said, oh, is that a spider in the corner? And all of a sudden, this little bouncy, ADHD guy, all of a sudden, like, where? And you see him on the videotape. And Thomas is like, well, I'll keep an eye on it. Could you answer these questions? Okay. And the child, that for the next hour, was answering. He got his interview done using the anxiety to inhibit in that period of time the impulsiveness for a bit.
I'll get myself a box of spiders.
Get spiders. Put them all over the place. You'll get your interviews done fast. So, any questions about anxiety from us before we move to depression? Yes.
All right, just a quick question. Dr. Wax, you said in anxiety-laden situations, you'll see different expressions of the impulsivity. What about if it's an inattentive type? Is it a different expression in terms of comorbid anxiety?
We'll get this all the time in our ADHD clinics. If you have someone who has anxiety, particularly in a school-based setting, it becomes extremely difficult without additional measures when you just ask teachers if someone looks off task, because
Right.
they may be distracted by their own internal worry pattern, or they may be distracted by their impaired attentional system. So when you're dealing with inattentive type versus anxiety, often it may be more of a one disorder presented as something else, although you can certainly be both. So usually that way we're trying to parse out, is it anxiety or is it ADHD? Whereas if you have more prominent hyperactivity, it tends to be not so much as one masking as the other, but as one kind of hiding the other.
Yeah, that's one of the toughest differentials, is ADHD versus GAD, or things along those lines, especially in the younger children, because it's hard for them to cognitively separate in their mind and isolate symptoms for you, whereas teenagers do a little better, but still. And that's where behavioral observation across a range of settings helps, with giving you good information. Other questions about anxiety? The phenomenology of? Okay, depression. Depression in DSM-4 and into 5, it'll be similar. Depressed or irritable mood, and with children we tend to see more of the irritable mood, followed by, or accompanied by lack of pleasure. They don't see things as enjoyable, and what you see, especially as they're heading towards adolescence, is dropping out of things, not interested in the things they used to be interested in anymore. You may see weight or appetite change. The sleep changes, insomnia. Insomnia is different than staying up late on the internet. Insomnia really is they can't sleep, or sleeping so much. But a lot of what we hear is that the kids are tossing and turning through the night, and then the internet starts filling their evening into the wee hours because they can't sleep, and you have this all mixed up then. You get agitation, or a very sluggish, slowed down kid with depression. A real loss of energy and fatigue during the day, which is complicated by their lack of good, solid sleep, which adolescents especially need. They will be so negative about themselves in the way, very good question asked, tell me about yourself. Oh, I'm not good at, is how they'll talk about themselves, And they feel very worthless and oftentimes guilty about things, that could be very broad in scope, from causing all the problems of their family to, friends, difficulties, and things like that. You again see impaired concentration. They're not remembering things well because, it didn't make an impression on them because they're not really in the situation that they're in, because cognitively they're checked out in terms of how miserable they feel, and they have a difficult time. What do you want in your pizza? I don't know. I'm not really sure I'm going to come to dinner. Okay? Recurrent thoughts of death or frank suicidality may be there too. Do you want to add anything with depressed kids?
Yeah, I think, as you said, the key in the younger kids is you can have children who present with overt sadness and will report depression, but that's very less likely. What you're going to get is an increase in irritability and these more physical symptoms. Mm-hmm. So certainly the lack of sadness doesn't in any way rule out the disorder, and sometimes I think we can get hung up on that. Irritability is unfortunately pathognomonic of having some type of distress, but it's very non-specific of what type of entity you'll have. So you want to look for irritability as a presenting symptom, although it doesn't always wed into one disorder. But particularly in depression, that's something that you're going to see more commonly the younger you are, and certainly in adolescence as well. Whereas adults, we can get a core sense of sadness. That's just more challenging the younger you are.
And remember, these symptoms have to occur nearly every day. And so with dysthymia, you don't diagnose it if the dysthymia takes a holiday in the summer when school's out. You don't have 2 months in a year where they're okay, let's say. And major depression is 2 solid weeks of symptoms. Depression, dysthymia is pretty common, for disorder, and major depression is more, you see this more in teenagers. Dysthymia we see much younger. These, again, co-occur with almost every disorder diagnosis in kids. Depression co-occurs with the externalizing disorders, conduct especially, and ODD, as well as with the anxiety disorders, and then other axis 1 disorders such as eating disorders and things like that. Prepubertally equal males and females in the younger cohorts of depression, but then with adolescents you start seeing the females being more prone. With the males, you see a lot of males who, have some conduct oppositional type of issues going on when they have depression in the teenage years. Dysthymia is more prevalent. Moderate stability in terms of it, follows the kids. Then once you have one major depressive episode, you are prone. We know that that's a high risk for future major depression is having the first one and having it young in the adolescent years. So it really recurs high. Sorry, that's the same. In terms of comorbidity, you see major depression is more comorbid with ADHD than dysthymia is. Same thing with conduct disorder. Major depression is up there, as well as anxiety disorders. But dysthymia you're going to find with OCD accompanying that, and PTSD more than a major depressive disorder in epidemiological samples. The risks are wide. Parental loss, divorce, death, different things like that, estrangement, abuse or neglect, as you see, just marital discord in the home. Peer problems are big, and of course peer problems, some sort of interpersonal conflict with a peer or even with a family member is one of those things in a depressed kid that is a signal for making an impulsively terrible act of harming oneself or attempting suicide. School failure, chronic illness, and low SES are all accompanied or risk factors for depression. And then the family characteristics, what we tend to see is that families who have parents with mood or anxiety issues, substance abuse issues, or in disadvantaged circumstances with families living in this way, these put kids at higher risk for depression. All right? There actually, the STAR-D, was a study of a depression in adults, found that if they treated mothers who had depression and followed the children who had issues, any kind of behavioral or mental health issue, tended to improve as moms who had the effective treatment improved. But we don't know if that's sustained. They have to follow these out more. And we also, the interaction, the main thing is that the interaction between the child's psychopathology issues and parent psychopathology issues, boy, these are like intertwined with one another. So we have to pay much more attention to family factors. Medical causes, you want to say something as?
Certainly not directly and indirectly. We always look for issues with substance use. Particularly in females, we can look for issues with thyroid disorders. Anemia, a little less common, but certainly can present. Medications, Accutane, especially in adolescents, is the most well-known. Nowadays, Chantrix, the quit smoking drug, has some concerns about that too, although newer data suggests it's not quite as bad. Liver disease and heavy metal poisoning, at least working in adolescents, that's more of a, I can't say I've ever seen that. But certainly in older patients, you can have a host of additional medications, from beta blockers to things like chronic obstructive pulmonary disease that can start to manifest as depressive symptoms.
I think Twisted Sister and Iron Maiden caused a lot of depression in the 80s. I don't know. That's my heavy metal there. Vulnerability, hardcore biological genetic factors, because again, you do see depression tending to run in families in some way, and negative life events again. But a big thing, is attachment and being, and if the child was insecurely attached or had a parent who couldn't attach to the child. So we've got to look at the early experience of bonding and making secure attachments within a family. And it could be on one side or the other, the child or the parent, or a mix, as predisposing a child for later depression. A big thing, of course, too, is affect regulation. But I got to say this. I also treat adults. I have a fair number of adults I treat in addition to kids. And whether I'm treating an adult with any kind of mood disorder or anxiety disorder, one of the big things I notice is that they never have ever learned really to regulate their emotions, and they could talk about it from way back, or self-soothe in a healthy way. So affect regulation, and this is why a lot of our work these days go after affect regulation strategies and teaching this to kids, because there's more and more ways that they are doing damage to themselves, from the kids who cut to kids who use substances for affect regulation or act out in other ways. These are key, and this is always disrupted in the mood disorders and often in the anxiety disorders. The social support networks and social behavior is also so important, especially as that teen is, if they already have disrupted social support or no social support networks and depression is starting to take hold, they're going down a hole very fast. You have to work really to help shore them up and connect them. And then, obviously, we talk a lot in CBT, especially about the cognitive biases and deficits they have for problem solving and communicating and effectively working in the environment. Let me just say, this is data from Kathleen Marikangas and her colleagues, again, under Ron Kessler, next to Ron Kessler. They studied a sample of 10,000 plus adolescents in the community throughout the U.S. It was representative of the population of the United States. It's called the National Comorbidity Survey Adolescent. And what this shows us is that this is from the age 4, 5, 6, from 4 all the way up to 18. And this is the cumulative percent for cumulative prevalence of diagnoses. The red line, the most prevalent class of diagnoses in kids are the anxiety disorders, starting as early as age 4, and you see they don't really peak until you get into the teenage years, but boy, oh boy, they are coming on and building and adding to one another, because you've got that whole range of anxiety diagnoses that are going in there. The next one, which really peaks here around 8, 9 years of age in here, these are the behavioral disorders. So these are your kids with ADHD and little ODDs. This is the next class of diagnoses to take hold in kids. This green line, which you don't see an onset now until 13, 14, really into 15 years of age, is depression, the mood disorders. So you're going to find anxiety onsetting early. The behavior disorders are next in childhood. Adolescence, you'll find then the mood disorders taking hold. And the last disorder is the substance use disorders. 16 years of age, 17 for those. These are the patterns of onset. So when you have a child presented to you, different ages, think about what may be present based on the epidemiology that we see of these diagnoses if you're wondering about what's going on. We always have to talk about suicide. People are afraid to, but we need to talk about this. Third leading cause of death in teenagers and in more boys than girls, right? And of course, boys use more lethal means. Depression, substance use, and prior attempts increase the risk of completing a suicide in these kids. And we find roughly 1 in 10,000 teenagers will complete a suicide, which horrifies you, but it is rare still, but at the same time not. You know, it's one of these statistics you have to wrap your head around in a public health sense. The thing about suicidal thoughts, we all have them. And kids especially, they have them. So they're not uncommon, okay? Girls tend to think, this is it, I can't live this life, more than boys do. But these thoughts are usually brief and passing, right? For some kids, though, they can be long-lasting. And when they start dwelling on it, and this is why, then, when there's especially an interpersonal conflict of some sort that the kid feels stuck in, and they don't have emotional resources to problem solve and manage it, impulsivity, some sort of attention-seeking act or some sort of desperate act, can take place which happens. And these thoughts about suicide are more common in teenage depression. Any comments?
No, I think you covered all the important points for depression.
It's teenage suicide, Bear, it's a tough one. Yes?
Yes, I have a question. After the trauma, a child or whoever has a trauma you have in the DSM-4, the post-traumatic stress disorder, blah, blah, blah. The question, is any traumatic stress disorder as it continues? So it's not possible. It's a traumatic time or extension, child. And my question is also, after, what happened in the schools here, all the killings,
So after the Newtown and similar types of events?
yeah, there can be any longitudinal studies in terms of depression, anxiety, sustaining time. It was increased, there was more anxious kids or more depressed kids, or sustained both, and it's media correlated.
Well, this is okay, so the question is, after you have traumatic events, especially those that are highly publicized in the media, is there more of a sustained response of anxiety or depression, let's say? That's an interesting question, and I will answer it by saying that there are several studies that cover this. I will say from the perspective of 9/11 in New York City, what was seen in terms of help seeking for mental health issues in kids and as well as adults in New York City post 9/11 tended to be people who had already had problems that were exacerbated by, but not new cases. So that's one thing to know. And those who are vulnerable have some risk and have already been struggling. These types of events could be more, if it's in their community, could be more of a release or re-exposure to something that brings them in for help. At the same time, though, a colleague of mine, John Comer, who's coming here to FIU as a new faculty in the fall, did a study post 9/11 of the impact of media on children's experience of anxiety post 9/11, and what he found was the way the parents talked about and dealt with the situation, and especially dealt with the media exposure and how to handle it, that made the difference whether the child developed more anxiety or less in experimental paradigms. So this is the thing. Again, it boils down to we have to look at the way that we respond in terms of parents or as, the adults in the situation when kids are exposed to an event, helping them and how to help them process it, which tends to be to answer things in a matter-of-fact way, but providing realistic information about safety and how things are being taken care of, not to leave their misunderstandings unattended, not to leave rumors and innuendos and things and scary things that they're hearing about unaddressed. Some parents are afraid to open the door and talk about it. I actually have a relative who would not let her children who were growing up in another state outside of New York have any, and these kids were like between 7 and 12 years of age. She didn't want them to be exposed to know anything about 9/11. I'm like, how in the world can you raise your kids in the United States today without knowing about 9/11? You can't do that because they're going to hear it from friends. You have to have dialogue, and you have to have a constructive, rational, and calm dialogue as a parent and as people around. When I was in New York City in 9/11, post 9/11 happened, about a month and a half out, I wound up at a cocktail party, and a well-meaning person, now I didn't realize how traumatized I was at the time too, I mean all of us who lived there, a well-meaning person at this cocktail party was like, oh, you're a psychologist, let me tell you what I'm doing. I'm an actress, and I got a whole bunch of people who are actors and actresses, and we've been going around to the schools and helping the kids reenact the 9/11 trauma. I'm like, I went nuts. I mean, I realized then that I was like, oh, I got to get out of here, and took a trip to Florida. But I was like, but I went crazy because they didn't, they weren't doing the right thing. They were trying to do their own version of trauma debriefing, which actually isn't the way to go. But woof. Yes.
Dr. Suicide as the third leading cause of death in teenagers and I'm assuming adolescents. What is the second cause of death?
Accidents.
Motor vehicle accidents.
Homicides.
And, yeah.
Accidents 1, homicides 2, suicide 3, I think.
Yeah, yeah. Accidents is one, I think homicides, yeah, is the second, and then, and then suicide. And then, because the thing, the interesting thing is child death, what is it? Oh, we're going to Google it and find, yeah, I think child death by illnesses and stuff is low.
Yeah, actually, if you add up, I don't know about cancer, but if you take up the next 4, 5, 6, 7, 8, 9, most of those leading causes are all medical diseases. You add them up,
Right.
even though teen suicide is rare, they don't add up.
They
to
don't
numbers
add up
for
to teen suicide. Right, yeah. So we'll get an answer. Yes?
Okay, this says that more boys complete suicide than girls, but girls are having more suicidal thoughts than boys. So is it that girls aren't completing suicide, but they're attempting as much as boys, or are girls utilizing resources, aren't as impulsive, aren't attempting as much?
All the above in that way. Boys tend to get access. Boys will use more lethal means such as guns. And girls are more ruminative, and don't take action as much. And then you have to also factor in things such as boys tend to be diagnosed more prevalent ADHD and disorders like that might lead to more impulsivity in that way. But mainly, one of the big things they see is access. For some reason, boys will take on the lethal big-time method like a gun, where girls might not. Girls tend towards more hanging and things like, or overdosing.
Yeah, a depressed ADHD male adolescent with access to firearms is a really bad mixture that should be watched carefully.
Right.
I had one more quick question about the suicide thing too. In Hawaii, the main way of hanging is actually, or the main way of suicide is hanging actually, because our kids' guns are hard to get in Hawaii, and hanging is the most common way. And we've had kids as young as like 4 or 5. And I'm wondering, suicide in younger kids, is that more of like an accidental thing, or do you think that they're actually doing the planning when they're that age?
That's a good question. I don't know. I don't know what to say about that.
Yeah, the
Accidental
actual
hanging.
numbers, I think there's been controversy about this because most of those deaths, I think people are very hesitant to label them as suicides below the age of 12. So it's very hard to get good data, and you're dealing with such small numbers.
Right.
I was working with a 7 or 8 year old child that was diagnosed with dysthymia, but when he was 7 or 8, he was trying to hang himself. And he wasn't very successful, but fortunately. But at that age, I was wondering if he even really fully understood.
Well, cognitively, they might not understand the permanence of something at 4 or 5 years of age. By 7, they're starting to get it. I don't know, but that I think is when you look at the larger data sets, when you really take a good sample of kids of that age, it's much more rare in that way.
Accidents, homicide, and then suicide.
Accidents, homicide, suicide. Thank you very much, Bill. All right, so we're going to talk quickly about diagnosing and assessing so that you can form a treatment plan for anxiety or depression as you're working with kids. Look, the big thing, I get it, you got to be economical. You got to work within what your system is and what it allows and supports in terms of if there's, your ability to give as thorough an assessment and use as much time as you can without burdening the family in terms of payment, because you have to work within what they can afford. And then also your system, if you're in a school system or, we have to be careful. So I'm going to ask you to think about these things in terms of what is feasible for you in your practice setting. The number one thing we want to try to do, and you heard in talks today saying, this study is limited because it was only self-report. Mark Atkins said that about one of the studies he reviewed. Multiple domain by multi-informant. In other words, we want to look at symptoms, the functioning, and how the child functions in different contexts, friends, family, academics, self-care. And we want to hear from the child's perspective, the parent's perspective, if you could get the teachers to weigh in, how you as a clinician, see the child, if there's any way of getting observation. Obviously, we'd love to have, the full Monty if we could, but we can't. But if you can try to get a couple of informants, that will help you have much more validity and, be more confident in what you're coming down to in terms of understanding the child. It's great to try and get repeated assessments, not of the big thing, but this could be very simple as just making a goal list or a problem list of 3 or 4 main symptoms or behaviors, and then asking the parent and teacher to tell you how they're doing on a 0 to 10 scale for each of these behaviors over the course of time you're working with the child. Some of us have the opportunity, mostly in research and sometimes in school settings where you have school-based mental health programs that are, have students working with you or postdocs and such, that they could go in, because they may be free labor to the school, to go in and get repeated assessments over time so you have an independent look at the child. But generally, you want to have multiple domains and multiple informants. We tend to use a diagnostic interview of some sort. Okay, shameless self-promotion. The Anxiety Disorders Interview Schedule for Children and Parents covers depression and everything else too. That's what I tend to use. I'm an author. Thank you. Who said that? You get a gold star. Thank you. I like the way you praise that. But some sort of interview, and within your own practices, you may develop something. If you take some of these standardized interviews that are out there, the ADIS, the Kitty SADS, and others, you may find ways of questioning or have lists. Like we have symptom lists for you to go through with the kids that you might just pull out and use. Believe me, I make no money off of this thing. Trust me. I can't take my husband out to McDonald's in New York with the royalties from this. But the thing that is, if any kinds of these interviews that you can find where you can get a problem list or a symptom list, and then it tells you how to question children of different ages, could be helpful for you to get around some of the differential diagnostic quandaries of GAD versus, separation anxiety and so forth. Fear and avoidance hierarchies, these are top 10 lists of what frightens you, but it's within a domain. Top 10 separation anxiety situations, top 10 social anxiety situations. This helps you. You put them on index cards. Each situation gets its own index card. The child sorts it into the easier ones to the most difficult. And then you rate them from 0 to 10 of how scary they are. And then you start working with the 1s and 2s early in treatment, and you build the child up to working with the 8, 9s, and 10s. Activity schedules are important for the child with depression. I want to know what you're doing this week. So every day you fill out what you did, how many social events you attended, how many success activities you engaged in, success being doing your homework or finishing a chore, how many self-care, soothing activities you engaged in, and the parent can be keeping a separate log of what they observe so you get the parent input. But activity schedules are important because you find out if the adolescent with depression is doing anything. And if not, you'll build in treatment around getting them to engage in pleasant activities and reinforcing activities again. Behavioral avoidance tasks, then these are little tests where we try to challenge to see if a child can handle situations that cause them to shrink away from something. So can they handle like role-playing a conflict with a friend? Can they handle the parent leaving the clinic for a few minutes and they not know where they're going if they're separation anxious? So these are all ways of assessing, and then of course there's self-report measures all over the place that you can download, some over the web, such as the Strengths and Difficulties Questionnaire and other kinds of measures you could get off the web. Otherwise, some you have to pay for, like the Multidimensional Anxiety Scale and such. The Children's Depression Rating Scale. This was one of the criterion measures for the main depression outcome studies. It's a semi-structured interview that you do with the child or teenager, and the parent could be there. And usually we want them there, or you do them separately and combine the information, but we usually do them together. It's got much more validity than a self-report measure because you're, as a clinician, able to prompt and pull a little more information and affect out. And the thing of it is, it's so focused, it takes about 20 minutes, right? Maybe that much?
Usually 15 to 20 minutes per informant.
Yeah.
And how you're doing it.
15 minutes maybe with the teenager, 15 minutes with the parents, or sometimes 20 minutes if you have them both in the room. I highly recommend taking a look at this. And again, like I said, it is the criterion measure. So we look at change in CDRS scores at the end of a depression trial to see if the CDRS score decreased. We know we got a treatment effect. Okay. You know what? This is out of place. It shouldn't have been there. This is an anxiety fear hierarchy. Just to note, this is an idiographic way that you can just very simply track whether your patient is changing where it comes to anxiety. And like I said, we start with index cards, and they list the situations that are fearful to them, so a separation anxiety hierarchy, and then they rate them from 0 to 10. Mom goes into a different room at night. She gets a little afraid of this. Mom goes out to get the mail. In New York City, that means mom has to go down the hallway, down an elevator, right? 25 or 30 floors outside. And, okay, so it's not just going outside and reaching outside the front door. That's a 3. Mom leaves the house for 15 minutes. Mom is gone for 30. I spend 30 minutes at a friend's house without my mom. Now she's getting up there in anxiety. 2 hours without mom. Spending a night is the worst. This is a hierarchy. What we do is you write these situations down on a piece of paper, or print them out, photocopy a whole 30 of them, and don't have the ratings on them. Every time the child and parent comes into session or comes in during the week, you give the parent the list, you give the child the list, and they rate where the child is at in terms of fear that week for each of these situations. So you get to see over the course of time while you're treating them, is it getting better? Are the numbers dropping, and or not? And if not, then you can work with what's getting in the way of your mood improving or your anxiety improving, and these also can be the targets for treatment that you work on. My gosh. Comments?
Short question.
Yes.
I understand that these are behaviors of feeling of the child, but in terms of the development of the child, the secure attachment, how do you make an inference of these?
The question is, I focused a lot on the behaviors, which tend to be our outcome targets in terms of what we can observe, what anybody could observe, whether a child could stay alone for 10 minutes while mom goes out. But the question is, how do we and where do we focus on the bonding, the parent-child relationship, the interaction? Let me say this. That's a good question. One of the toughest things to do, especially in 3 hours or whatever this is get at the whole flavor of what you do in psychotherapy. If you are a good cognitive behavioral therapist, you are a good therapist. If you are a good psychodynamic therapist, you're a good therapist. You have to pay attention to the whole enchilada, okay? It's got to be the relationship of the child and the family, where they are, what the bonding is, how they relate to one another, what the child's aspirations and dreams are. You've got to understand this all. So your diagnostic assessment is going after the diagnoses, but that is couched in your assessment of what the milieu of the child is. And the milieu needs to be internal as well as external. So I'm presuming that, and it is a big part of what we work with overall, because I've got to pay attention to how, and assessment is always the great place to start getting a sense of how these individuals who are living together are relating to one another, how they picture the child, how was she brought here or he brought here in the first place, how did they couch the problem, in what terms, and relate to one another, and so forth. So we're going at nuts and bolts here, but we're presuming, that you're attending to the whole child. And then the other thing, which Bill brought up this morning too, is your relationship with the child, and that therapeutic alliance is key. I don't care who you are, how much therapy you've been doing, or has been done to you. If there's not a therapeutic alliance, and if there's not everything Roger's told us about trust, positive regard, warmth, genuineness, you're not going anywhere with the therapy. So we've got to make sure all of that is always there. Thank you for reminding me. You want to add anything in?
No, I mean, the same thing is true with medications, in all honesty. The question I had for you is, what's your experience about the validity or the practical usefulness of and practicality of getting teacher report for internalizing disorders?
You know what? Teacher report is so important. You know, it is so very important for whatever the presenting issue is. And, you know, so we tend to use the CBCL, and then there are some teacher report forms for the mask and a couple of things, you know, they're not so well standardized yet, but at least, you know, we're looking to see what are some of the items that they are touching on. But a big thing I like to do, now I don't know how the schools are down here anymore. I went to high school down here, so, but, and thank goodness they didn't do the kind of grade report we get in New York are narratives from each teacher. So they get a grade, but they also get a big narrative about how they're functioning. And it's amazing. What we tend to see, like with the kids who have social anxiety, social phobia, is the teacher writes 2 or 3 sentences. If it's ADHD, you're getting a page and a half. That, though, is, you know, that's telling me something. And parents will say the same thing. I'll ask them, tell me what happens when you go to a parent-teacher conference, and the parent of the child with social anxiety will say, well, they never really have much to say because they don't really know her. Oh. You know, so teacher report is very important because the teachers let us know if that child's invisible, which anxiety tends to be invisible 2 to 7 years before it's diagnosed, or if that child with ADHD is in their face and they're becoming a problem. We actually have a child right now we sent and did an independent observation on. The teacher did not know who that person was there to watch. And what they uncovered with a child who has ADHD plus anxiety is that this one teacher was so negative to the child. You know, and so it was a reciprocal hate each other society going on. But that's, you know, and it was the weakest subject that child, you know, has had. So I think teachers are very important. So
practically, if you can get a CBCL completed by a teacher, you're happy with that as a useful measure of feedback.
I'm happy with that, but we're also going to try to talk to them, if we can. Yeah?
In our school system from Iowa, and we actually created what we call just a referral packet, because we were running into, if we said, oh, this is an ADHD referral.
Oh, right. We don't say that.
They were diagnosed before we ever got the information to
That's
the
right.
physician, you know, kind of thing. But we did like the Connors forms, but we had to get away from them because they were too expensive. As a school district, we just couldn't afford them. So we ended up kind of creating our own tool. We pulled together like the autism, you know, all the different ones, and put them all in one form so that when we hand this packet of information for the teacher input, they have no idea what the students may be being considered to be evaluated for. We just called it a referral. So,
Right.
But what tool you mentioned?
Well, let me say this. The Strengths and Difficulties Questionnaire is in the public domain. And there is a website that you could go to there where it scores it for you. And I think teachers can do it online. Anyhow, the SDQ, New York State uses in all its mental health centers because it's free, and it maps well. It's correlated with the CBCL. So the SDQ is a very good measure. And what I like about it is, unlike the CBCL, which is just a list of problems, the SDQ is strengths and difficulties. So you also get, you know, what are some of the resources the child has available. So that's SDQ is excellent.
It's
Strengths
short, and
and
free.
Difficulties questionnaire, and it's free. And like I said, the website is outstanding because you could download things, and I'm not sure, but I believe you can, like, you definitely, if you input, you'll get a score, and you get a summary and readout. You could print out a narrative about the score, but I think you can set it up where some people are taking it online too. But don't quote me on that going that far. Let me just go. Let's move ahead because wait a minute. Are we doing okay?
3:15, I think we break.
3:15. We're going to take a break.
You have 20 minutes.
And then how much time do we have after 3:30? We come back
As long as we want. No.
till 5.
We're supposed to end at 5. By 5, let's say that.
And you need an hour, right? Yeah.
I can make
Okay.
it with an hour.
Now, let's power through a little bit more here. Let's say this. When Bill said that people flights problems disrupted in New York and up the Eastern Seaboard, I let out a yay yelp because I'm supposed to fly out tomorrow. Oh, please. Oh, please, please. I hope it's megastorm happening up there. Oh my gosh. Anyone go to the Aventura Mall? I've never been. I passed it on the way here. Is it good? That's it. That's Thursday evening. Friday is Boca Town Center. Oh my gosh. All right. Cognitive behavior therapy. Here we go. We're going to do 15 minutes, take a break, and then you're taking over. I got to sit down.
Fair enough.
Goals of CBT in the context of everything with the genuineness, warmth, and therapeutic alliance and everything else, let's bear in mind. We want to educate the children and their parents about the nature of anxiety and depression. If you remember Animal House, that film, the opening scene, the statue of the president of Faber College says, knowledge is good. Knowledge about your disorder is good. You have to know where do these moods come from? Why am I anxious? We have to normalize a lot of this, that we are human beings and we are subject to fluctuations in the way we feel. And we also have to understand our feelings. So all of our treatments start with what we call affect identification. What are the different things that you might feel, I might feel, he and she might feel in the same situation? We can have very different feelings. So understanding, and then understanding, how normal it is to be aroused and, different things like that, and understanding it's normal to be sad at times. It's normal to be angry at times. It's normal to get afraid or anxious. But then where does the line get crossed and how? We have to educate our families about these things. So that's what we do. And then we also socialize them to understanding CBT. Why this treatment for this problem? Why are we doing this? And what are we going to do? Everybody gets training in some form of somatic management. We're going to go through more in detail with some of these. We want to attempt to change their inner talk, how they're coaching themselves. Encourage proactive behavior. So instead of withdrawing in depression and escaping in anxiety, being in there and managing, it's extinguishing the reactions that they have that are so negative when they're provoked, solidifying their skills, and promoting generalization so that they take it home with them. And it's not just you have a kid functioning in your office. What good is that? You want them to be able to function where they are. Now, things we have to remember. Depending upon the age and stage, this is going to influence the expression of their symptoms and their issues and disorders. And you see maybe more parental overprotection when they're younger. You might see more parental arguing and, upset when they're older. Different things because of the expectations everybody has at the age that the child is, and also what the child can handle given cognitive development and such. Internalizing disorders tend to be overlooked. And we have to also remember that these kids aren't living in a vacuum. They are subject to their thoughts and feelings, everything's subject to the influences by what's going on around them, where they're living, who they're living with, what their neighborhood is like, what the school is like, all this stuff. What I say, I did my training in Oxford, Mississippi, an idyllic little town that Faulkner grew up in. And now I work in New York City. The advice I would give to a parent of a 12-year-old who's saying, is it okay to let my child walk to school on their own now at 12, is different for the parent in Oxford than it is for the parent in certain parts of New York City. You've got to take into account what's going on and where they are and what's happening. Definitely let the New Yorker walk. The kid in Oxford could ride his bike. He'll be fine. Elements of these protocols. The big thing from this slide is exposure to what they're afraid of if they're anxious, activating them to get them out of their rooms and out of their funk if they're depressed. And whatever treatments you're looking at in terms of what's been studied, they have to have exposure or activation in them, or they typically have those as the most essential key ingredients to, these are our molecules. When you look at drug studies, what's the molecule that is, studied in a particular pharmaceutical agent? Well, our molecules are exposure for anxiety, activation for depression. Okay? In terms of psychoeducation, which all of our treatments will have, we normalize the response. We break it into understanding it, into what I think, what I'm feeling physically, and then what I do in terms of my behavior. When we teach kids to do that, and their parents, it makes more sense to them than because they've been sort of overwhelmed by the, this thing of anxiety or this thing of depression. These things feel just so big to them. But when you break it into its 3 parts, and especially by using daily diary forms where they're tracking their thoughts, their feelings, and behavior, they then start to understand what triggers their responses, and they start to be able to see their patterns. And that's important because then they can make sense of it for themselves. We engage the kids, of course, depending upon the age, to be a detective, be a scientist, or to study yourself, to understand what is causing you, not what causing, but what is prompting certain reactions in you, and what are the outcomes of the way that you are behaving when you have certain kinds of emotional reactions and responses. And then, like I said earlier, we then help them understand that we have cognitive interventions, we have somatic interventions, and we have behavioral activation and exposure interventions that are going to change those little components and help them to adapt differently and behave differently, in situations. Everybody's going to get some form of somatic management to a point. For those of you in school, somatic management is so important when you're working in school systems especially, and it's one of the things you could teach teachers to do in a classroom that will help reset the climate of a class as much as it helps to reset kids. Here, we want kids to develop and understand, first of all, we want them to clue into their bodies and understand the difference between a steady, neutral state, an aroused state, or, a more somber, depressed, or down state. Because we want to be neutral most of the time, but there are going to be things that are going to prompt us in one direction or the other. And the thing about kids who are anxious or depressed is that when they get a prompt in either direction, up or down, usually it's that first prompt that they run with into that emotion. There's not a stop, think, deal with this. There's just, or, And this is the thing, the natural prompt of any given situation. You know what? We changed our plans, and we're not going to get together this week, so sorry, you're going to have to find your own thing to do on the weekend. Oh. That, for a child with depression, becomes a spiral of, oh my gosh, no one likes me, I'm done, I can't take this. Or, sitting in class and the teacher assigns, next week, we're going to have a book report due, and here's the book, I'm handing it out, and you got to read it, you've got 7 days. 7 days, how am I going to get this done? Because, oh my gosh, I have that math test coming up also, and I think we're supposed to go to my cousin's party, and I'm not going to be able to do, okay? They wind into the emotion without taking that arousal or that and saying, wait a minute, what can I do with this? These initial become a signal to fall apart in some way. So we have to help them to recognize that any kid who people have changed plans on in the last minute and left out to dry would feel annoyed, would feel, upset about it. Or any kid who's got a lot on their plate and now the teacher's just put something else on, would be worried. These are normal reactions, but they're taking them as signals to go all the way. We don't want to do that, all right? So the first thing we want to do is help them recognize when their body does its thing and use that as a signal to wait through it and develop some types of resources to keep the somatic aspect under control. The simplest thing all kids, anxious, depressed, can do is breathing retraining. Hand on the belly. The idea that there's a tube from the back of your throat and your nose, back of your throat, all the way to the belly that has a balloon at the bottom. And what we want to do is just inhale slowly into the balloon and exhale slowly out. Inhale slowly, relax as you exhale out. Should be 3 seconds in, so 1, 2, 3. Pause, relax, 2, 3. And we do 2, 2, 3. Pause, relax, 2, 3. My Pilates teacher hates that I do this because I'm not using the core in some way. I don't know. 1, 2, 3, relax. And you count to 10. 1, 2, 3, relax, 2, 3. 2, 2, 3, relax, 2, 3. 3, 2, 3, relax. Slow diaphragmatic breathing. This, those of you in school systems, get teachers to do this with the whole class. Everybody visualizes the tube, a balloon. The balloon could be any color you want. It's standing next to the desk after recess, after lunch period. Everybody listens quietly as you do the deep breathing. It'll settle the whole classroom. Get them all, they sit down then and they get back to work with all the, they're hyped up from recess and lunch. Now you got them focused again. But this is also something to do for parents and kids together, especially younger kids. Teenagers, we want them to do it on their own. It's a simple, portable, somatic management technique. And when they are prompted with an event, they can learn to be breathing like this, to keep themselves calm without anyone knowing that this is actually what they're doing. But they're managing their uh-oh or oh no responses. All right? First thing you do. You could go into more progressive muscle relaxation training. We tend to do this for kids who have generalized anxiety that are always ramped up. And after we turn off the television, we turn off the iPad, we turn off the iPhone, we turn off the computer, we turn off, all that electric stuff at like 2 hours, an hour and a half before they're supposed to go to bed. We stop homework about an hour before they're supposed to go to bed for teenagers. Then we want them to do their nighttime routine, brush the teeth, put on pajamas, and do about 20, 25 minutes of tensing, relaxing muscle groups. You could download scripts about progressive muscle relaxation or MP3 things or whatever they're called off the web, and also mindfulness exercises, all right? Or you could take them some guided imagery, but that's all just for calming and focusing. Cognitive work in anxiety, depression is so key. Okay, question, everybody, I might have done this with some of you before if you've been to the workshops I've done here, but let's all imagine this. You have a 5-year-old who's going out for t-ball for the first time. The child goes, the mother is told, go home, come back in an hour, we don't want parents here. And the coach takes this little kid, gives him a glove and says, go stand out there by second base. If a ball comes to you, you got to catch it. Okay. Little guy gets out there and he's standing there and he's looking at the glove. It's wow, ooh, smells funny, yeah. And the kid gets up to bat, hits the ball. This kid is standing there holding his glove and he's watching the ball comes and the ball drops. Oh. And with that from the sidelines he hears, put the glove on already. Oh gosh, hey, I gave you the glove so you could wear it. Put it on, you got to use the glove. Okay, the kid, left hand, right hand, puts the glove on. Next kid gets up to bat, hits the ball. Here it comes. It's like, oh my gosh, the ball bounces in and out of the glove. And the kid hears, oh, what the heck did they send me this year? A bunch of kids who don't know what they're doing? You're supposed to catch the ball already. Okay. And this is how it goes. When that mother comes to pick that child up, and they'd go home and the mother says, oh, tomorrow's another t-ball practice. Aren't you excited? How's that kid going to feel? All right? Now think of it this way. Let's wipe him out. The kid goes, is dropped off, never been there before, first time. The coach gives him a glove. Go out there, and the kid's standing there looking at the glove. Ball comes, drops right next to him, and what he hears is from the sideline, way to keep an eye on that ball, Jake. Okay, next time, put the glove on. You could put it on, and you could hold it up, and let's try to get the ball in the glove. Okay, guy? Way to go. Way to go. Okay, kid puts it on, stands there. Ball gets hit. Goes like this, the ball pops in and out. Yeah, that's what I like. You really did that great. You put the glove up. Excellent. Now, next time, close the glove as soon as the ball hits it. Okay, way to go. You know you're doing a great job. Even if it goes on like that, you know, how is he going to feel about playing t-ball again? The point being, cognitive restructuring, I present that to parents and to kids, and I ask them, which coach are you in your own head? All right? Because when you are working with people who are anxious or depressed, they are coach number 1, they're not coach number 2. So we have to help them to clue into the way that they're thinking, the thoughts they're generating that are, oh no, I'm a bad person, I don't know how to do this, it'll never work out for me. And we have to help them develop rational, focused, effort-based thoughts, changing the distortions that they develop. These are right out of Aaron Beck, all or none thinking. I either ace this test or I'm a loser. This is the worst thing that could happen to me is catastrophizing. Fortune telling, I know I'm never going to make friends at that camp. What's the point of going? Right? Mind reading, I know my teacher thinks I'm stupid. I know those kids think I'm a geek. I like to say, what am I thinking now? Come on, you're very good at knowing what other people think. What am I thinking now? You know, working with the kids to understand. And then teenagers, I always tell them, stop shoulding all over yourself. Shoulds, can'ts, and won'ts. Albert Ellis used to call these masturbating. I must be perfect. We've got to get them away from the negative self-talk and coaching themselves into a hole. And we do that by disputing how likely is it that these things happen, you know, every time that you go out to go to camp, or what does Mary's opinion mean? Does it reflect that of everybody else? I like the kids who say, you know, I don't go out because all the kids in my school do drugs. So I don't go to any of the parties. This is classic for a depressed teen or socially anxious teen. I'm not going to any of these dances or parties. Everybody's doing drugs. How many kids are in your school? Well, there are 4,000. It's like, what do you go to, Zombie High? What, are you kidding? This is, okay, you know, so, but it's helping them to see not everybody's on drugs, or not everybody's mean, and so forth, because they've had experiences that may not have been, you know, positive. But they have to dispute the automatic thoughts they have. If they are younger kids, we use a superhero or a sports star. No more Lance Armstrong anymore. He's done. I don't want to get into his head. What is Derek Jeter? He's our hero in New York. What is Derek thinking when he gets up to bat? Little kids, 6, 7, 8, will say, oh, he's thinking he's going to put it in the left field, or he's going to hit a line drive. These kids will say stuff that are very affirmative. And you say, oh, really? Why isn't he thinking, I don't want to do this, everybody's looking at me? And they laugh. Oh, Derek doesn't think that. Does Derek hit the ball every time he swings? No, sometimes he gets strikes, he even strikes out. Really? Does he tell himself he's a loser because he struck out? And in fact, we have data. I have Mets data and Yankees data on how many strikes versus how many home runs. That's a good one to show kids. It's unbelievable how many strikes in a season versus home runs. And you say, why isn't Derek giving up? He strikes out a lot, all right? And the thing of it is, because Derek tells himself, he focuses on, he's practiced, he's rehearsed to be here, and you know, he understands this pitcher is throwing certain kinds of sliders or whatever, and he's going to hit the ball a certain way or do his best to try. But the thing is, he's not going to give up if he strikes out. So the kids have to learn the coaching style of focusing on on effort rather, not outcome, and to be realistic and to practice, okay, and give themselves chances to cope. with that, why don't we take a break? I'll finish up CBT when we're done with the break, and then we'll keep it going. Yes?
Can I just ask you a question? There are a lot of materials already available out there for these various concepts. You know, there's Kendall's model. And
Yeah, the coping cat.
Are there any that you're aware of that employ videos or
Kendall's Camp Cope a lot. Phil Kendall has a DVD-driven CBT program, Camp Cope a lot.
I've seen the manual, but never the CD.
Yeah, it's great. It's a DVD thing. And then I think John Wise, with the STEPS program, had one for depression that is interactive with the web. I think, don't quote me.
Because for very young children, what I think would be really great if if you could do some of this stuff with animated, because they're so into they're so into video games.
Yeah, there's a lot of these technology-driven types of methods. There's one that comes out of if you go to the abct.org, Association for Behavioral Cognitive Therapy, also Division 53 here at FIU, if you hunt through, you will see some people who have some of these programs that they either are developing or are out there.